Thank you very much for joining. I would really like to welcome you all to this, I can say first ever joint project between Sarcoma Patients EuroNet and the Connective Tissue Oncology Society, CTOS, which we entitled Global Patient Involvement in Sarcoma Care. And by the way, this is also the first official pre-meeting of CTOS. So we are actually kicking off CTOS with this meeting. Nice to know that. And my name is Bernd Kasper. I'm medical oncologist based in Mannheim, University of Heidelberg, Germany. And I'm represented in both organizations. I'm an appointed member of the SPAEN board, and I'm also a member of the board of directors of CTOS currently. So I thought it's ideal to launch this project, and that's what we actually want to do. So the main idea of today's, we called it a kick-off meeting, as it should definitely be only the start of what we have in mind. So the idea is to really identify gaps and challenges in global sarcoma care, and we want to do this from both perspectives, from the patients and from the experts' perspective. So what is the situation? What are the gaps and hurdles? And how do we see possible solutions for the future? But before jumping into the topic, I would actually like to hand over to Roger Wilson, and I'm sure you all know him. He's the honorary president of Sarcoma Patients EuroNet, and he will give you a bit of a background what SPAEN stands for and what Sarcoma Patients EuroNet wants to achieve. Roger.
Thank you, Bernd. Yes, we just want to explain a little bit about SPAEN so that it's clear in the mind of our professional colleagues what we're about and where we're coming from and why we do what we do. We're the international network now of sarcoma, GIST and desmoid patient advocacy groups. We started with a European focus, but gradually more and more people wanted to be associated with us. And we now encompass some 50 member organizations around the world. We are all patients, survivors, caregivers, patient advocates, and of course some people are active patients, are actually on continuing treatment. So we have a lot of experience of what being a patient is about, and we're motivated by that into helping other patients and to seeing that we can improve things for the future for all of us. Now, our experience and our expertise has been developed and encouraged by so many of our professional friends, many of you on this call today, and we're grateful for that sharing and that learning that you've given us, because it does help motivate us. It motivates us to help you where we can, as best we can, and it also helps us because we can activate and mobilize patient groups to support the work that is being done in research by our professional friends. We set ourselves some fairly straightforward goals when we started, and these have been modified and have evolved during the 12 years which we've been working together. Defining the obstacles and challenges to improving sarcoma care is a top priority. That's quite clear. We know from our personal experience what those challenges are and the obstacles many of us have had in terms of getting proper care. We want to identify, agree and advance relevant knowledge. We respect the evidence that has been developed scientifically through research. And we want to make the resources that evidence has shown have value available worldwide, all sarcoma patients. Now, research requires funding. We can't provide it, but we want to help identify it We want to help bring it in from whatever sources it comes, whether it's governments or philanthropic research funders. To do that, we can't replace anything. We've got to work with what is there. We've got to build on existing relationships. We're not about changing the world. We're about helping the world evolve and work better for us. Coordination is a very clear priority. I think we've shown with the work we've done in the early days in Europe, with the very strong support we had in these earliest days from Professor Blay. We have helped research become coordinated and to become more patient-centric. We think that's valuable. It's valuable to you as professionals. It's valuable to us as the patients who receive the care you provide. We want to find the questions that matter. We don't necessarily know the questions to ask, to know which questions we should be asking, if you follow that. And I have to work on together how we deliver benefit to people with sarcoma. Excuse me. And finally, there's also this issue of raising the awareness of sarcoma, particularly with professional colleagues who maybe have little contact, little knowledge of the disease because of its rarity, and who suddenly come into contact with a sarcoma patient and don't know what to do, don't know how to proceed. We want to raise awareness so that that lack of knowledge can go, can disappear, can be part of the past, if we can. Catherine? I hope you've seen this paragraph. It was a paragraph that I wrote, nearly a year ago now in an email to Bernd. And I was thinking very hard about CTOS and the long association I've had with it, and how we might actually gain benefit. And it just struck me that the whole issue of collaboration, it just has to be what we build upon. I think if we can work together, the association with CTOS will give us stronger power in the way we can argue with healthcare systems and challenge the management of care. But it will also help CTOS, because by bringing in and understanding what patients can offer, by bringing patients in to support the development and design of research, I think we can develop more ambitious targets and meet them. And frankly, I think collaboration opens up so many doors, and I want to see it happen. Bernd, back to you.
Yeah, thank you, Roger. So coming back to our collaborative project, these are the main objectives. Of course, we want to enhance the patient voice in sarcoma care and also sarcoma research. We want to foster this joint, and this is important, on a global scale, expert and patient collaboration. And the idea, of course, is to have a joint publication at the end of this meeting or after this meeting as a kind of put out, and where we want to define a priority list of projects to be worked on together, maybe let's say for the next 5 years or so. So this is the agenda. Next slide. For today's meeting, what we have done, we have divided the whole topic, or we try to divide the whole topic into 4 chapters. And each of us, or 1 or 2 representatives from our community, are moderating that. We will start with a clinical topic, optimizing clinical care in sarcoma, then overcoming healthcare system challenges, working on cross-border challenges, and last but not least, driving research in sarcoma. And at the end, Catherine and me would like to maybe summarize that, and the idea at the end is to come up with a priority list of projects, which will certainly come up from the topics we have discussed before. But there is also room here for maybe other topics which you think are still important or maybe important to include here. Next slide. Just a few keeping notes, Zoom keeping notes. Yeah, of course, we want to talk, we want to discuss and speak with you, but I think it makes sense to do this in a coordinated way. Please raise your Zoom hand if you want to speak. You can use the chat, but what we want to avoid is actually that there is a kind of parallel discussion in the chat going on. So please speak up. We are a rather small group, so I think it's quite easy. The session will be recorded and published, just to let you know. Okay, let's get started. The first topic, optimizing clinical care in sarcoma, and I will hand back to Roger for that, for the starting of that first topic.
Thank you, Bernd. It's of course a huge topic, and we started to boil it down by just putting the headlines on paper and deciding which of them should really rise to the top of the pile. Early and accurate diagnosis was clearly something which I think impacts on everyone. It's something of which I've an unfortunate experience, although that's a long time ago now, thankfully. We wanted to look at survival and survivorship strategies and rehabilitation. And we also wanted to think about palliative care, the care of our patients with terminal and declining health through this disease. So starting with early and accurate diagnosis, even if it's suspected, sarcoma is hard to confirm. It needs to have a surgeon or a doctor with knowledge of sarcoma to actually confirm it. Now, that knowledge may come through a specialist multidisciplinary team, or it may be a surgeon who's perhaps working alone, but in a wider network. But it'll be someone who's got experience of sarcoma, because we're talking about clinical assessment, we're talking about imaging, and we're talking about pathology. So an accurate diagnosis is then critical because the characteristics of different tumours call for different therapeutic strategies. We have no evidence to suggest that any country doesn't have this diagnostic problem. You know, we need more data about that. And we think that something quite radical is needed to address the issues of getting an earlier, accurate diagnosis in every healthcare system. It's an area where in the UK I've long been concerned, partly because of my own personal experience. But we've made some great steps forward, but we still have this problem. Our specialists tell us that there are still high percentages of patients that come to them having been incorrectly diagnosed, inappropriately treated because of an incorrect diagnosis, and they have the challenge of sorting that system. So the two issues which we felt might be good topics for us to consider were increasing awareness for some sarcomas amongst the non-specialists and endorsing some core principles on global standards for care, which help us define specialist roles and get that specialisms recognised more widely in healthcare systems. Any thoughts and comments on this area first? Do I detect that everyone agrees with me? Oh, I see lots of nodding going on. And thumbs ups. Well, so Bernd, can I suggest that those items 1 and 2 on our notes we might put forward as principles to move forward with?
Judith, I see your hand.
Philip.
Yeah, so I was wondering, also one of the raising awareness, I think, is a very good thing, but also centralization, I think, is a very important issue. Is that something that you consider to promote even more, or?
I think we should, but I don't know whether you saw it about 6 months ago. David Thomas in Australia and his colleagues did a paper on the challenges in some communities for centralization. You know, in Australia, the huge areas to cover, relatively low populations, don't justify a centralized service. So I think we must also respect the challenges some of our communities face in this. I think there are answers, but I'm not going to try and suggest at the moment.
I think we live in an era where with digitalization, it's more easy to ask experts to look along with radiology, with pathology than it was years ago, and especially with the COVID time, that increased even more, and it's even getting more easy to ask a colleague to look at your digital slide than it was before.
Yeah,
I think it's something that we really should promote, especially for pathology. I think it's crucial that expert pathologist, or there is some kind of reference panel that people can turn to.
Yes, certainly. That's certainly a point, which we, by the way, will come back to that point later. There are a couple of other hands raised. I think Bill was first, then Laureen and Mandy.
So Bernd, thanks, and Roger, wonderful talk. And just quickly, you know, in the US, I think one of the issues we have is the heterogeneity of our system and how difficult it is to manage to get patients on the right path. And in a large part in the last few years, our system is becoming more broken, overwhelmed, and harder for patients to, you know, feel that they are being seen by the right doctors at the right time for the diagnosis. And I think that's something to consider here, how we can help navigate that system with the heterogeneity of healthcare and insurance, and just how busy the system is, which I think would be something we'd love to also discuss when it comes to rare diseases and sarcoma.
Yeah. Laureen.
Thank you, everyone. And so just to go to the point of centralization, you know, in low to middle income countries, while it might seem like a solution, it puts an enormous amount of pressure on the actual patient. So it solves the issues when it comes to the logistics and the delivery for the healthcare system, but it puts an enormous amount of pressure on that patient trying to access that healthcare system. What I would look at doing, though, and perhaps the answer is not so much centralization as standardization, and looking that wherever a healthcare system chooses to put their services geographically, and that those services are equal to what, because that answers what we need, what we ultimately want is that patients are getting the right treatment, the right time, with as few challenges as possible, making sure that there's equitable access and so on. So if we can look at perhaps looking at standardization rather than centralization, that might be a suggestion on
that's actually exactly what we have in mind when we say that we would like to have a kind of minimum global standard of care and define some kind of criteria for that. So this would definitely be an idea. Thank you, Mandy.
It was just relating to what Roger said earlier about what was going on in Australia. Obviously, we have different health systems in each state. And I come from Western Australia, where we actually have the only state sarcoma service where there is a formalized referral pathway to a centralized service compared to the other states. And so it's quite interesting to see the differences. Yes, we get all the sarcomas being referred through to us at the state sarcoma service, but the pressure that puts on the team when there isn't the resourcing to actually provide them with the the manpower to manage all of that, given all the problems that we have with funding in our health service. It's an ideal scenario, but really difficult with the resourcing that's available. And I imagine that we are certainly not alone in that one, that the resourcing is what limits so much of these ideal practices of good referrals and speedy referral to a multidisciplinary specialist team.
You're right. Yes, I think you're right there, Mandy. I think the challenge of resourcing even impacts on some of the the Western first world nations. In Western Europe, we have challenges in some countries. Phil, you're on mute.
Oops, sorry, thought I clicked. Yeah, I'd go back right to the beginning of this, and it's almost as a pre-diagnostic phase with regard to patient awareness and how long it takes for patients to realise they actually need to go and get some form of help, some medical advice, how long they leave symptoms for prior to accessing that help. And obviously that has a significant prognostic impact. And then obviously some countries in the developing world and some countries even in Europe don't necessarily have an established primary care system, but let's say a first point of contact target, where I think that, as Roger pointed out in the intro, there's very much a lack of awareness around sarcoma among all the other rare cancers. Then they account for 50% of them. Of cancers overall. So I'm not sure over time we've tried to sort of look at awareness from a sarcoma and from my perspective, a primary bone cancer perspective. That's sort of quite a small voice when you think that, you know, the proportion of cancers is what, less than 1%, that are sarcomas, were less than that. And when you're looking at an awareness program, what really is the incentive, or are the incentives for any first point of contact medical professional to actually engage with that sort of program when they're probably going to see one or two of these presentations in a career, when there's obviously a huge emphasis on other areas? And I think it's a question I don't have the answer to, but I think it's a nut that we need to crack, and that can be universally cracked, so that it's a, I suppose, it's transferable knowledge and transferable processes that we can use across the globe now, as we are.
Yeah, interesting set of reflections. That, yes, yeah. Lauren, you're coming back with a.
Yeah, sorry, just to buttress what Phil and Mandy said with regards to resources. One thing we're probably, if we're looking at a global point of view, is to acknowledge that the majority of patients diagnosed globally will not see an expert, a sarcoma expert, because the health system they exist in simply doesn't have enough sarcoma experts. So their primary health care will not have sarcoma experts in it. So you would have to look to create something that allows the existing primary health care to be aware and educated on that, and know what to do with someone once it's there. And then to understand that once they go for treatment, they might not be treated by a sarcoma expert. They might be treated by a general, radiation or clinical oncologist with not many things, but who would need some sort of support in understanding that what an expert would do. So creating those linkages between the non-expert healthcare care professionals and the expert international healthcare professionals is maybe a way to do, rather than trying to create or assuming that there are sarcoma experts in the country. South Africa is one of the highest Kaposi sarcomas things in the world, and it's not, and I can tell you now, it's not diagnosed enough. And there are probably 2 experts in the country of 68 million.
Yeah.
And that's not their full-time job. They're only experts because they do it a lot.
Yeah.
Let's hear the medical points. Jean-Yves and John.
I completely agree with what has been said about the resources. One thing I'm wondering, and maybe want to reiterate something which has been alluded to, is the value of expanding the technology on artificial intelligence for pathology reading and also for decision making, because I think, and that's going to be a general problem, even in countries which are equipped with reference centers. Number of cases that we see on a weekly basis is really overwhelming, and we need to find a solution to facilitate this flow more efficiently. And I really believe that technology can help us in this direction.
Yes, that links in very strongly with what Judith was saying, of course. Yes. John, welcome.
Hi, everybody. This is a great event. Thank you for hosting it. You know, it's a great group, and I'm very excited about everything I'm hearing today so far. And so I would just like to make the point that as sarcoma specialists, there are areas that we need your help, and that is breaking down barriers. Patients have so many barriers to getting access to sarcoma pathology experts, recommendations, and clinical trials. And so through the pandemic, you know, I saw patients from all over the world through telehealth. And in the United States, I saw patients, you know, as we all did, through the United States by telehealth. And in the United States, the government is making that much more difficult by not allowing insurance companies or healthcare providers, even Medicare, to allow us to see patients from other states. And, you know, I can't speak for the rest of the world, but in the United States, anything that an organization like this can do to remove barriers to telehealth would allow us to reach more patients and reach more even physicians. And also, this is true for clinical trials. We can do remote clinical trials, but there are certain barriers that are not allowing us to remotely treat patients with experimental therapy. And any help that this organization can provide in really breaking down those barriers is very much needed.
Yeah, very good point. Thanks, John. Robin, good to see you.
Yeah, likewise, and thank you so much for the invitation. I'm having trouble with the Wi-Fi here, so I'll keep the video switched off. But just to say, I agree with everything that's been said, and almost as a follow-on from Jean-Yves' comment and John's point, I agree that technology and telemedicine can really make a huge difference. But certainly from the UK perspective, and I'll be really interested to see what Roger has to say about this, it does need an initial investment from the health authorities or from the government to sort of get things up and running. So, you know, almost a sort of, you know, pump priming in a way to get that sort of system up and running. It needs that initial investment. And I think, you know, with regard to telehealth, I think it really helps a lot. And similar to John, we get referrals from all over the world, and I think the COVID-19 pandemic has certainly made it much more accessible and easy to organize tele appointments.
Yeah, thanks, Robin. Roger, do you have any other burning issue you would like to raise here? Because otherwise we then need to move to the second topic.
Can I just quickly comment on something Robin said?
Yeah.
And that is, I think, the political involvement and the political drive, where it is possible to get it, in a country is absolutely crucial. We were very lucky in England. 15 years ago, we had a government which was listening to the challenges that cancer was presenting, and we had a national cancer director who had treated sarcoma patients. So we found a ready ear and were able to make our voice heard. And I think the benefits that we have in England at the moment have come from that.
Agree, Roger.
Okay, thank you very much. That was a very good start. Next topic. Overcoming healthcare system challenges for the management of sarcomas. This will be moderated by Sorrel Bickley from Sarcoma UK. Sorrel, the floor is yours.
Thank you, Bernd. And I mean, interestingly, the two themes that we have pulled out in terms of overcoming healthcare system challenges are already themes that we've begun discussing. So the first of those is around access to specialist centres and multidisciplinary teams. And we also wanted to invite you to spend some time on discussing that topic of healthcare professional education about sarcoma. So because we've already started to delve into that kind of specialist centre MDT topic, perhaps if I just take a brief step back, and really the principle coming into this is ideally sarcoma should be treated in a high volume centre by a multidisciplinary team because of its complexity, variability, many subtypes, and its rarity. But that requires an enormous amount of expertise and experience in order to achieve those outcomes. So we know that on a global scale, there are a huge number of challenges here. We're speaking particularly around small countries, countries with a large rural population, countries that are just less densely populated in general, particularly countries with lower income. And I think for globally, resource is a challenge across the board. So in actual fact, although we have this principle of a specialist centre, multidisciplinary team model, I think it's been picked up really effectively already. The majority of people aren't treated in this way. So I agree with what's been picked up already, that there have been opportunities in the last couple of years around virtual models. We're starting to see more use of a national multidisciplinary team, or even international models. So I think I'll just kind of open the floor again on that theme of how we could start to move that dial and make use of those opportunities that we have to give more people access to that specialist care. And now everyone feels shy again. Phil, I can see your hand. Wonderful.
I think that what we've highlighted is that there's a whole number of steps really when it comes to in the diagnostic pathway, from the pre-diagnostic sort of patient awareness agenda right through to first point of contact of primary care, then through to an MDT team or whatever that looks like in the country we're talking about, and then through to sort of specialist diagnostic services. I don't know if there's probably no data out there to suggest where the biggest level of impact is on prognosis. So, for example, is the biggest area of positively impacting a prognosis for a patient early diagnosis at primary care, so early referral into an MDT system, or is it an accurate pathological diagnosis, or is it actually the use of an MDT system? And I think to prioritize where we go with this, we've got to look at the areas where the impact is the greatest, because that's potentially out of low-hanging fruit. I mean, it might be the hardest area to go at, but it's the one that we're likely to make the biggest impact from a numbers perspective, from a prognostic perspective. So I don't know if there's a piece of work that is a huge piece of work, but that needs to be looked at, and whether that's a data search, I don't know, but I think it'll direct our energies, because obviously we don't have endless resources, so we've got to direct them specifically to look at the areas that will give us the highest yield.
Yeah, I think that's fascinating, and it is a huge piece of work, but it is something that would really require that kind of global approach. So it's certainly in scope for what we're discussing today. Sarah, can I invite your comment?
Yes, hi. Thank you for inviting me today. So just something to consider. The LifeRaf group, instituted something called virtual tumor boards. So whenever we have some interesting cases, and this can be around the world, we invite a physician to share their case using a virtual platform. And we invite experts from different disciplines to share and comment on the case. And even if the physician who presents it, it's not just him. He can invite colleagues from his institution, fellows, just to learn and sort of be trained on like the management of these rare sarcoma cases. And it doesn't even stop after that. Like we may try to make the connection with the physician who's presented the case on the tumor board to the experts. And we really try to share that as a best practice, moving forward. So when there's cases in these countries where it is really challenging to know what's the best way to go about managing these cases, we do our best to connect them through virtual technology and getting experts on the call to connect them in terms of how to best, what their recommendations are in terms of the management of those patients.
Thank you, Sarah. I think that's a really welcome example, and we've seen a successful introduction of what sounds like a similar approach in Italy over the past year, and I know it's certainly being used a bit more often in the UK, but I'm not so aware of any international evaluation of that approach, so that could be something to explore more as we move forwards. Marcus, I can see your hand.
Yes, thank you. So it's really great to see so many committed people here. So it's really great to meet you. So looking to our discussions and maybe looking out to the pre-readings, I think one of the central words we already use, but we can also find through the document, is awareness. And I think awareness is a very, very important topic, but we need to do a much better job in awareness also on an international level. Awareness doesn't mean that the whole world should learn about sarcomas. That's not possible. We don't have the resources. We don't have the finances to do this. So we need to do a much better job in building up a strategy. What does awareness really mean? What are our objectives in awareness? What are our target groups? But what do we really want to achieve with awareness? And we will not be able to make individual changes if someone is doing a little bit awareness here and another person or another group is doing a little bit awareness there. I think we need to work much better on a global scale or on an international scale to really target awareness in a specific way, because awareness and communications, lobbying, advocating, these are central issues to change topics within our healthcare systems.
And can I just explore that a little further, Marcus? Are we speaking public awareness, or is this amongst healthcare professionals, or all of this?
No, my understanding is public awareness doesn't make a lot of sense, because, as I mentioned before, if you try that the whole world should learn about sarcomas, you have a waste of communication. You don't have the resources to do this. I think we need to think more about what are our messages, what are our objectives in doing awareness, what are the right target groups that we want to reach. So we are talking about early symptoms. We are talking about expert care. We are talking about research and a lot of different other issues. And I think we really need to have a better exchange on the topic of research, and maybe some coordinated action in a specific way, because sometimes I get the impressions that some groups in some countries, they do some awareness maybe to raise the awareness to their organization, or they raise the awareness to fundraising or whatever they do. But the question is, what do we really want to achieve by raising awareness and moving forward together?
Thank you. I'll come to the other hands we have up, and then there's just been an excellent question in the chat from Lauren, which I think I'd like to come back to. But before we do, Annika, next on my screen.
Yes, hello.
Hi.
So I am from Finland, so from the country where there is just a few hundred cases every year, and we don't have specialized sarcoma center. And what I always try to remember to bring up is the language barrier. If you think about the Eastern European countries or Scandinavia or Asian countries, so there is a problem with the awareness anyhow, like the patients and the doctors as well are not always very professional in English. So it's not enough to just to do everything in English. And then there is another thing is that when there is countries that we don't have the specialized sarcoma centers, there is actually no chance for getting sarcoma specialists, because the doctors who are specializing in some areas in their studies, they don't have the sarcoma specialists to go to learn to. So we are not getting sarcoma specialists because we don't have any sarcoma specialists. So it's kind of that's something that I hope that the international community somehow could develop some kind of international specialization path for like doctors who are interested but don't really have the specialists in their own country. That's all I have to say.
I think that's really valuable, that idea of building capacity in sarcoma expertise, for sure. Thank you, Annika. Anna, I'd love to hear from you next.
Hi, everybody. My organization focuses on osteosarcoma, and I'm an osteosarcoma survivor for 10 years now. And I really agree with what everybody is saying, particularly Marcus. I think that if we want to provide value as an organization, I think the focus has to be back on the beginning, right? Start at the beginning. If we're asking our doctors to collaborate, we have to collaborate, and we have to come up with a plan to provide value. And we're looking at doing this internationally, if I'm guessing here from the conversation. So if we go back to the beginning of diagnosis, which many of us are patients, what did we do? What's the first thing you do? You go to Dr. Google and you Google your diagnosis. What the heck is osteosarcoma? What the heck is angiosarcoma? What is this? So once you have your Dr. Google sit down in a calm frame of mind and figure out what it is you're actually dealing with, then what's your next step after you get that information? And if I'm guessing, the next thing you do is you find, this is what I did, how do I find support for this? Where do I go? Who do I talk to? Where can I find somebody who survived this? And this is maybe the awareness piece, where also you go, okay, in this space of where do I get treatment? Do I stay put? Do I go to a sarcoma center? What is a sarcoma center? How do I find a sarcoma center, a multidisciplinary center? Do I stay put or do I travel? And then you're also wanting to serve the physician community and the caregiver community, or the professional community. So if you're in a rural setting in Southwest Australia or wherever, Rwanda, I think that the tumor board is a really valuable thing. But again, you have to, as a clinician, you have to know where to find this information. So where do you go? How do you find out that there's a tumor board for osteosarcoma, in Vermont in the United States? How do you find this tumor board space? So if we're really providing value, we can kind of have chapters for this organization in different parts of the country, and we create, it doesn't always cost money to create awareness. It can be, and in our case, it is a grassroots organization. You meet somebody in a waiting room while you're waiting to see your clinician, and you go, hey, have you ever heard of this organization? They've really helped me out. And same on the clinician side. Hey, you have a sarcoma patient. You really need to know about this this place where you can get information and get care. So I think the awareness piece is very important, but I think you have to start at the beginning. Where will people find the information? How will they find you if you're providing the relevant information?
Thank you, Anne. That was extremely well put, and also lovely to hear you have a cheerleader agreeing with you in the background too. We like that. And I think we're coming to the end of this section, but I do just want to move with that momentum as we're going towards that kind of awareness, healthcare professional education piece. And I think Lauren put something very interesting in the chat about focusing on primary care. And I think there are many avenues open to us, some of which will have minimal impact and some of which can have an enormous impact. So I would just like to open up comments on where are the areas in terms of awareness and improving early diagnosis where we can have the most effect in moving the dial, focusing on the fact that we are driven by a network of patient advocates. So, is it medical school education? Is it influencing those professional bodies? Is it sarcoma clinicians going out there and spreading their knowledge, or is it patients directly going out there and that kind of grassroots approach? So I'd just love to invite a few comments before we run out of time on this topic. And Vandana, you're first in the queue.
Yeah. So I want to connect two things. One is what Marcus had said about, using resources, and the other is what you're talking about. So, to go back into the history of Indian scene, we find that most of the sarcomas are diagnosed very late because the doctors are not aware and the patients like to believe that it is some orthopedic problem, which is not sarcoma, because they don't know about sarcoma. So one thing I feel, if it can be done and if it's a possibility, that, we make enough pictorial guidelines to show that what sarcoma is like. And those can be put in the clinician's, waiting area. So when a patient goes there, he may get an opportunity to read or see those and then question the doctor about it, say that, do you think this could be sarcoma? And then maybe the doctor becomes more aware, and obviously any doctor or clinician who's going to allow the use of these posters in the waiting area would know something about it. And so the moment somebody asks, he becomes more aware of it, and then he wants to talk about it. Maybe that will help us in diagnosing cases early and also creating a lot of awareness, because I may have a broken bone, but if I read all this, next time I meet somebody, I may pass on that information to a lot of people. So maybe the social media and other things may not be the most effective, but this might be the more effective way to do things.
Excellent. Thank you. I can see the hands are flying up. So I will invite Lauren to give a comment, and then I think I'm handing over to you next, Jean-Yves. So I'll let you have the final word, and then I'll let you and Marcus pick up. So Lauren first.
So my first thing is there's nothing more that irritates me more is when you sit down in an oncologist waiting room and there's a signs and symptoms of breast cancer pamphlet sitting in the oncologist waiting room. It's a little bit late for that. So, and I think to that point, the idea of where we focus global education needs to be with sarcoma. We need to come to the point that we'll never have a breast cancer. We don't have a breast cancer. We don't have a prostate cancer disease. It's not a sexy cancer. So are we going to be able to convert patients into understanding this? No. So who's the next line of defense? And that next line of defense are the primary healthcare workers and the primary and the doctors, the primary healthcare practitioners. And I think, to create something and an education on that, you spoke, about, in school and that's the easiest way and the most cost-effective way to make sure that you're getting those diagnoses, because you're never going to get a woman, in the case of breast cancer, where a woman says, I felt a lump and I want a mammogram. You're never going to get that in sarcoma, because there is simply not enough money invested, unfortunately, in this to do it. So the pragmatic approach is, well, let's make sure that the gatekeepers into the healthcare system are equipped to deal with symptoms. Patients will come to a doctor with a symptom. If the symptom persists long enough, 90% of patients will go to a doctor and ask it. Problem is when they get turned away from that primary healthcare scenario, or that scenario becomes long and drawn out, trying to find a solution of what this is, that's when they fall off the wagon and they don't get on that. But for symptoms, a patient's going to consult someone at some stage.
Yeah, I think that's very strong, and that angle of pragmatism is key, and something where there's a little, almost on the sneaky side that we're exploring in the UK is to try and get where med students are studying rare cancers as a module, to try and get the case studies that they're using to be sarcoma case studies. It's not a way of influencing the big picture, but it's a way of getting examples of sarcoma out there. So I do think that pragmatism option is something we need to be thinking about. But Jean-Yves' hand has disappeared, so I'm going to come to you next, Akira, if that's okay.
Yeah, that's what I wanted to have. We should have we should have the Japanese point of view here. Akira.
Yes, please.
And then we move on.
Deal.
Thank you for giving me opportunity. I'm Akira from Japan. Actually, tonight, no, it's a morning or evening, maybe. 3 Japanese joined this meeting. I'm a doctor from Japan, and also from 2 patients from Japan. One is Terumi Oshida. She's a survivor of epithelial sarcoma. And the other is Takashi Shimura. Is also a survivor of some kind of sarcomas. The awareness. As an orthopedic oncologist in this field of sarcoma care, everybody knows that the early stage sarcoma cures quite well. So the most important and most simple way to improve the prognosis of sarcoma patients is to diagnose the patients as early as possible. But screening, such as gastric cancer or breast cancer, is impossible for sarcoma patients. It's very rare. So the awareness of the patients and also the awareness of the general practitioners is the most important gatekeepers for diagnosis, early diagnosis of sarcoma. So for such patients or such doctors, the most important message must be very simple and easy to understand. For such example is that golf ball campaign in the UK. It's a very simple way. So I want to ask all attendees of this meeting, such kind of social campaign might be taken in your countries or not, or is it effective or not? I want to make some questions to the attendees. It's my question. Thank you.
Thank you very much. That's a very big question, and maybe that is an excellent one for us to pick up as we pull out our themes at the end of the session about a global awareness campaign. Wonderful. So I will close there before my session overruns too much, and I'm handing over to you, Marcus, and Jean-Yves, I believe.
Yeah, thank you. Maybe Jean-Yves, you would like to start because already I think we covered some really interesting aspects that already covered our topic of cross-border challenges. And we also put some work together in our pre-document, and I'm sure we could have put more information into the pre-document about the inequalities in cancer care, but also in sarcoma care. So I think our main approach was more to look to ideas and really to foster the exchange instead of coming with solutions. Jean-Yves, I think that was our idea, to give really room to the audience and discuss these issues based on our pre-document.
Yes, thank you very much, Marcus. Actually, by preparing this session, the question of cross-border healthcare, which is actually very connected to the point which were the points which were raised just before, came out as both one of the solution and also probably an important statement that we should have in our mind, is that the best for the patient is to find in his own nation those ways and the resources to get a proper diagnosis and a proper treatment. And I like very much the idea often presented by Paolo Casali of networks around the world, helping to connect the patients to the right hub in an urban spoke manner in a place which is within its own country. Even though admittedly, and we are all discussing here globally, admittedly, not all countries are equipped with reference centers. I think that's one very good way to initiate the process. And probably one of the questions of cross-border, which we did not mention in the document prepared by Marcus and on which I added question, is this idea which was just brought at the end of the previous discussion, which was what are the key factors which will make a difference? And clearly, the key factors which will make a difference are very different from one country to another. Listening to the previous discussion, it is quite obvious that training dedicated pathologists is something important in some countries, less important in others. Informing at the level of within a given country on where are the reference centers, maybe more the question in other countries. This is also connected to the structure itself of the healthcare system. To which extent does the healthcare system favors the idea of sending the patients to a distant place to get a treatment in a reference center? Is this something which is encouraged, discouraged? I think some countries, the Nordic countries, the UKs have a lot of things to tell us on this perspective. So cross-border healthcare is something which is a nice solution. I think the first step of the cross-border again is something which we needs to be around education and exchanging information and probably training. But the two questions that we had identified with Marcus are not around this one, and they are again connected to one of the questions that we raised before, is the idea of international multidisciplinary tumor board. And listening to this discussion, actually, I realized that there are two levels of discussion in that, and that's something where we working on this kind of network of networks, if you can say so, which has been initiated as an experience within the European Union called EuroCan. The idea to have MDTs to which the patient and their doctor can refer to in the country or outside the country is quite attractive. But we have probably two levels. A first level is how to get the information, which is absolutely crucial at the moment of the diagnosis, so that you do not lose a chance because the diagnosis is appropriate and the mode of diagnosis and the first-line treatment is organized appropriately. That's one level, which is extremely important. I think this is one of the levels to which we should work more. The second one is a bit different, but it's also important. We have the procedure of diagnosis and treatment is well known, but here the case is complex. And in this case, not all centers, not all reference centers do have the expertise to do such a complicated surgery, or even maybe some very complicated other treatment. In this case, MDT may have a slightly different role, and the two are of course connected, but they are really different in the magnitude and the service that we can offer. The second question that we had identified with Marcus is quite connected to that actually. Cross-border healthcare is something which is useful in situation where within the country, the treatment cannot be found. If you think globally, this is happening, but this is not that frequent actually. The most important is to get the information where the treatment can be diagnostic procedure and the treatment can be done appropriately nearby in your own country, because that's so much more easy to organize, much more easy even in regions such as Europe, where we're trying to organize cross-border healthcare is quite complicated. So these were the two questions that we were raising with Marcus. MDTs, international MDTs are certainly quite useful, but they can have different levels of questions to be addressed, and they can serve different purposes. And on the basis of their work, how to organize patient cross-border, and that's something which is very dependent. We discovered that in the European experience, very dependent on the organization of each individual healthcare system. Marcus.
Okay, any comments on this, or maybe also any experiences? So maybe we can also go to countries and maybe ask the countries what are your maybe expectations, or what are your needs in this direction? Because as we mentioned in the pre-document, we are very used to see a lot of things through our European or maybe American glasses, but maybe go around the world in different areas. Maybe the challenges are very, very different, and maybe also the solutions are more local or regional solutions. So first of all, Piga.
Hi, Marcus. How are you?
Good. Good regards to Chile.
Yes, thank you. You know, something that I think that's quite important in countries like ours is creating awareness and educating the health professionals on the primary care system, because that's where the patient gets first. And if we want to get an early diagnosis, that's where we should focus. So the patient is as soon as possible sent to a center of reference. And I think that's in many cases, that's where cities where there's not a center of reference, the patient usually goes to a primary care, and that's where he's going to be derived to the appropriate place to be treated. So I think that there's a place where we should do awareness and of what they should look for in a case of a sarcoma patient.
Thank you, Piga. I think that was one of the topics we already discussed in the previous round. So we are already back to awareness, and the question is, what does awareness mean, and what is the main direction or the main objective of awareness? So next speaker, Paulo, welcome.
Thanks. No, my point is that I completely agree with Jean-Yves that the organization of the national health system is crucial, because clearly we cannot speak the same language. I mean, even as far as awareness is concerned, I mean, depending on the features of the local health system, you will have completely different problems. It's even difficult in Europe, so in a continent in which health systems are quite similar to each other, but I mean the situation in Italy is different from France, Germany, and so on. So I guess that it's very difficult to find solutions globally. Second, I believe that the international multidisciplinary teams, team meetings, may be important not for single patients. And in fact, this is the problem of the European reference networks, which were conceived at the very beginning as something like that, so by which a European network could provide teleconsultations single European patients. I mean, if you imagine the number of sarcoma patients across Europe, you immediately understand that this would be, but it could be useful to have this kind of meetings to fine-tune the practices across centers. I remember that at the Milan sarcoma conferences, maybe some of you recall the clinical discussions And we discovered that in spite of the fact that we completely agreed on the contents of clinical practice guidelines in Europe, but also globally, then the single cases could be managed quite differently across institutions, across sarcoma reference centers all over the world. And so I would say that this kind of meetings, which now I see that, I mean, some of us are organizing, I think they could be a very important thing from the, of course, even from the educational point of view, but even more, I think, as a quality of care instrument. I mean, to fine-tune, to harmonize more the way sarcoma patients are treated, even at reference sarcoma centers.
Thank you, Paolo. There is Carol.
Hi,
Hi.
Carol Swallow from Toronto. I wanted to make a comment about the types of tumor board. You were alluding to very different functions, Jean-Yves. And I participate in a variety of sarcoma tumor boards, 4 per week. And one is a provincial sarcoma tumor board, which is open to all primary care practitioners, nurse practitioners from across the province that we're in. They're able to come and present cases, discuss the imaging, indications for biopsy. So the pre-diagnostic phase, which I think is really what we're, I think, focusing on here, is how to get the patient into the system appropriately in the first place. So I think that kind of tumor board that is not so much, you know, the fine details of which kind of surgical approach, but just, is this likely to be a sarcoma or not, and how are we going to figure it out? There needs to be some kind of facility for that. Then I'm also in an international retroperitoneal sarcoma tumor board that we have once a month, which is for borderline unresectable cases where we're, you know, the surgeons are discussing, oh, you'll have to, you know, take that nerve or that vessel, a whole other level of discussion, which is also equally valuable, but not really, I think, the emphasis of this kind of group, where you already know what you're dealing with, you're just discussing the fine points of how to manage it best. So I think the first kind of tumor board, where you don't even necessarily know it's a sarcoma, is where the emphasis should be put.
Thank you. Maybe can I go back to some of the participants? So maybe I would be interested to hear more about what is the situation, for example, in Japan. When you are practicing in Japan, are you getting maybe requests from other countries out of Japan in where patients are seeking for support, or maybe going to Australia? Is there something like an exchange where patients are seeking help from outside Australia?
So as you might know, the situation of Asia is a little bit different from Western countries. The sense of value in Western countries, especially in EU, the sense of value is almost equal or identical, I think. But as you already know, there are a lot of different countries in Asian area. Sure. And especially in this pandemic of COVID-19, there's almost crossed country by country. So in the last 2 years, we have very few, actually now, no sarcoma patients from outside Japan.
Okay.
Is it possible to transfer the patients in EU countries or not?
Yeah, I think we already mentioned this in our pre-document. We as Sarcoma Patients EuroNet, but also as a German organization, we receive every week, we receive emails from patients in Europe, specifically from Eastern Europe, seeking for a second opinion, for example, in one of the Western sarcoma centers. And our main challenge is not just to send the patients around. The solution is not sarcoma tourism by sending the patients from country to country. I think that's not the solution, because very often only a few patients can afford this. The question is, and we already mentioned this in the pre-document, what does the patient do with the information from a second opinion when he or she is back in her Eastern country and no resources are available, where you don't have a qualified surgeon, or where you don't have a qualified radiotherapist, or maybe an oncologist? So the solution can't be sarcoma tourism at the end. I think we need to strengthen each other, and some of the solutions have been already discussed. Just Paolo mentioned this, and also Jean-Yves mentioned this, by doing these kind of international collaboration, but also by transfer expertise and knowledge, and also transfer experience. There is, for example, just a very small example, there's one of the leading sarcoma centers in Austria. They have something like a partnership with a sarcoma center in Romania. So they work very close together, and they deal with these cases and with the expertise and with the experience just between two centers. But this also will help the patients in Romania, for example. So the question is, what could be solutions? And we already discussed some of the solutions. Roger.
Yeah, thank you, Marcus. I just wanted to give the one example that I know of where patients are actually referred across borders. Slightly strange one, because it's the Republic of Ireland and the UK. And the Republic of Ireland is a country with a very dispersed population, a very small population, although it's not a very big country. And of course, the UK is highly concentrated. And we've moved to specialist centres, particularly with bone cancers, the primary bone tumours, many years ago, 25, 30 years ago. And Ireland sends the difficult primary bone cancer patients to the UK. The simpler ones, where it's maybe an amputation or removal of tissue leaving the limb otherwise intact, they will handle themselves. But where, it's, for example, it's an endoprosthesis or some extensive reconstruction, or indeed those occasions when reversing the lower limb, to become an upper limb with the ankle as the knee. I can't remember what it's called now as a technique. Where those sort of things are possible, they come to Birmingham. They're not treated in Ireland. And that's fully agreed by the Irish government, and it's relatively straightforward. There have also been cases of patients with rarer soft tissue tumours being referred into the Marsden, I believe, and fully funded by the Irish government. So it is possible, it can happen. But there's a lot of history behind that one, which makes it easier to happen today than perhaps it might otherwise be if one tried to start it today.
If we talk about cross-border, and maybe looking back to the discussion, or maybe the statement from Carol, so it's not always looking on cross-border about cross-border from country to country. Maybe it could be also cross-border from region to region within one country, as I understand this so far. And maybe this is also a situation other big countries have, like in India. So maybe can we get some feedback from India about what is the situation in India, maybe by cross-border healthcare within India, when you go to region? Maybe from Vardhana, or maybe from Dr. Agarwal. I already have seen him.
I think Dr. Agarwal will be the best person to talk about it, since he's doing the clinical work in it. So may Dr. Agarwal?
Well, India is a little different because we have very few sarcoma centers of excellence still in the country for such a large population. So patients will most often go across the states, but it's not very easy for people from out of India to come unless they know the language,
or they know somebody, or they have a company which is tied up with the medical tourism company, and we can come up with to the hospital, because getting visas, translations, all that is something which is a little difficult in many areas. But most big hospitals now in India do cater to patients who want to come from the countries, at least in the surrounding areas, like from Bangladesh, we get a lot of patients. We get from Sri Lanka, we get from the Middle East.
Okay.
And we are now getting a lot of patients from Africa as well.
Okay.
So I think where the local access to sarcoma care is poor, that is where these patients seek out and come to India.
Okay, thank you. So maybe Annika, one of the last speakers, because I think in the interest of time, we have to move to the next topic.
Yeah, I was just thinking about that because, for example, in Finland, we don't have the proton treatment at all. So I know that the patients have been sent to Sweden or Germany for proton treatments. But I think the biggest problem here is that we don't have enough, we have very few sarcoma trials, and patients are not sent for trials out from Finland. So that's the thing that I know that sarcoma patients would like to attend trials, but they are not they can't go. So that's, for us, that's the problem more than the treatments.
Okay. So thank you very much. Jean-Yves, any final comments or?
No, I think the discussion could probably last for long, because obviously this topic can be analyzed country by country, probably region per region, with different conclusion. One thing we should probably have as one conclusion is that our major need is simple MDTs able to solve simple questions to people who are not absolutely not aware of what is a sarcoma. This is what is the most useful, and this is where probably a collective action can make a big difference in big numbers of patients. And of course, that's also our mission, even though that's challenging in terms of volume.
Maybe just a final question to you, Jean-Yves, but maybe also we can think about later on about this is not a final solution, but we have to start somewhere. And we just learned that the situation is quite different from country to country. So the question is, would it help if an organization like Sarcoma Patients EuroNet would start with something like, let's call it a global atlas of the situation of sarcoma care? Because I know that some other organizations have already done this to get a better overview of what is happening in the different countries. Because I've just learned about India and just learned about other areas, but maybe to get a better overview what happens in the different countries, maybe we should think about such a basic information collection up to an atlas, how care and research is organized and qualified in the different countries.
I think it's a very good idea, because it will also be like a guide to the other countries on what they can do and what they can learn. Because, like somebody may be lacking in some expertise or some area of work, and then if they get to see an atlas where something else is being done, maybe they can get in touch with them, or they can do those type of things in their own country.
But one of the key things on that idea, Marcus, is that it has to be kept up to date.
Yeah,
it's a big job to make it.
Yeah,
it's actually an even bigger job to keep on top of it and make sure that it's always current.
Okay. So thank you very much for the discussion. So back to you, Bernd.
Yeah, thanks, Marcus and Joy. That was really great. So we come more or less to the last topic now, which is an equally important topic, of course, driving research in sarcoma. And we couldn't have selected somebody better than Denise Reinke to moderate that. It's your job, Denise, now.
Thank you very much, Bernd. For those that don't know me, I'm a nurse practitioner at the University of Michigan, and I've been engaged with patient advocacy through the development of the Sarcoma Coalition, which is a group of groups in the United States, as well as I've been privileged most recently to be working with the SPAEN board. And so we're going to focus this last section on looking at opportunities for the sarcoma advocacy groups and community to partner with the researchers to really drive forth research, recognizing how key research is to understanding sarcoma and also for improving treatments and outcomes. And in the pre-work, we captured several areas, and we could probably talk the rest of the day on this subject of where are the opportunities for us to work together to help drive forth research. But we decided to focus our attention, given that we have such a nice kind of, even though it's not totally comprehensive of representation across the globe, we have nice representation. And so we want to take a look at where there's a void in the research across the world, and where is there some opportunity, and what are the challenges, and how could we collaboratively work together to try to identify the opportunities, to overcome obstacles, and then lastly, how do we more effectively bring the voice of the patient to the research table, if you will, to be able to identify where are those important inflection points, and how can we really help make a difference to effectively drive research forward. So with that, by way of just a brief background and introduction, I really open up to you to hear a bit about perspectives around void in research and clinical research. What are the issues related to this? What are some of our challenges? And how can we work together to overcome? I think, Annika, you kind of started out a bit with that discussion in our last section. You didn't realize you were making a nice segue for us to discuss into clinical trials where patients want access, but sometimes there are large areas where there are voids and they don't have access to those new treatment opportunities. All going to be so shy? Is it such a big problem? We have no keen jump-in solution. I know that many of the research community, we've had discussions along the way to really explore how do we work together across borders. Jean-Yves, please.
Thank you, Denise. To kick off the discussion, I think research, by definition, cannot be distributed everywhere, depending on the nature of research. One of the key things for the success of research in sarcoma is our capacity as a community to refer patients to one center which is equipped with an adequate clinical trial for the given patient. That's something which is important. So that's the first type of research. A second type of research, which is probably as important, is to be able to collect in real life what is happening to the most exhaustive patient population that we have in our centers. This is the best way to, this is a thermometer of what we are doing routinely and where should we improve. And that is also clinical research, I think. And both research are a bit opposite in the because they are demanding different things, but they are as equally important, and they should be distributed around the world. And again, it's a question of networking, right?
Yes, and many of the advocacy groups have really a keen interest in capturing that patient-derived real-world data, and then how do we begin to collectively collaborate internationally. So I think that this is really an important discussion for us to be having. John, Trent, I see your hand up.
Hi, Denise. Great to see you.
Good to see you.
So during COVID at our center at Sylvester, we developed the capability to see patients on clinical trials remotely through telehealth, consent them virtually, and deliver self-administered medications to their home. And we were successful at doing this with patients who were already on our studies. We shipped experimental medicines to sarcoma patients in Russia and several South American countries. However, we were not allowed by the pharmaceutical company, the sponsor would not allow us to consent the patient for their first visit. We had to see the patient for one study, or for all of them. The sponsors required us to see the patient in person for the first visit, and they just wouldn't budge on that requirement. And this study was the nirogacestat study for desmoid tumor, which we could have easily enrolled several patients on the study, but they couldn't travel during COVID. There's similar barriers even without COVID, but we have the technology and we have the capability to enroll patients on clinical trials from remote locations. In this situation, the barrier was the sponsor. And certainly advocacy groups, such as everybody on this call today, can continue to put pressure on sponsors. In this situation, the FDA and the government were allowing this. They were endorsing this, but it was the sponsor that wouldn't allow us to get to much needed therapy to patients.
No, that's a great example of the importance of the collective voice, right? Of bringing these groups together and seeing where there's opportunity to advocate. Corey, I see your hand up.
Hi, Denise. Thanks for calling on me, and thank you everybody for putting this together. This is an extraordinary group of people, and I'm excited to be part of it. I want to just follow up on one of the things that John was saying, and then also talk just about translational research more generally. I just, from my own foundation, which is Angiosarcoma Awareness, where I'm an advocate, cut our first check for multiple flights for one patient to fly to a very promising clinical trial where they already have data suggesting that this could be of clinical benefit for her. She would not have been able to participate in that trial, and the trial in exceedingly rare sarcomas often just cannot accrue patients. And so from my advocacy hat, it seems to me that bridging the gap between getting patients to the trials or the trials to the patients, as John was just advocating for, is of absolute critical importance. And I say this coming on the heels of my day job, which is through the Broad Institute of MIT and Harvard to generate data. And we've generated data in angiosarcoma, and that angiosarcoma data actually was part of the lead up to some of the clinical trials that are now launched and unable to accrue patients. So you can make discoveries and you can get data out there, and it can be real and it can be validated and published on. And if you cannot bridge that gulf, there's no point in any of it, really, if you think about it. So I think as a community, thinking creatively around solutions to really bridge that gap, I think there's multiple angles. I think advocacy groups can absolutely directly fund patients to travel. They can push on policy, which is probably something I think if we had a collective voice would go way farther. So I would strongly, I would love to be part of something like that. And so I just want to make that pitch to everybody there just to see what we can do as a community. And then the second thing is, we definitely need to generate the data. And so through, I just want to, this is relatively new, the platform that we generated out of the Broad, we just opened it to all cancer patients from the US and Canada. And I'm sorry, we can't internationalize it, but at least people in the US and Canada from any cancer can come and be part of this. And we generate clinically annotated whole exome sequencing data and just put it out there to the community for free to try to enable other researchers to make discoveries. And one of the things we've been doing is talking to folks like Robin and others from other countries about helping them set up similar installations where at least the clinical and the clinical and the genomic data can be harmonized using standard standardizing everything, so that even if they're separate studies, they are in essence generating the same data that can be taken up and harmonized after the fact. So join countmein.org, send all your patients.
Oh, thanks for sharing that. And that is an obstacle that hopefully with technology improving, that this harmonization of data across where people are collecting it in different areas, platforms, that will be able to bring it together. So thank you, Corey. Mandy, you had a comment to make.
Yeah, just to very quickly, one about the clinical trials, Australian patients have a terrible job getting access to clinical trials. We're really, really struggling for that, simply because trials are not effective in Australia because there aren't enough sarcoma patients, the story that we all know and share. The other thing I just wanted to share with you is that for research funding here in Australia, there is the community voice is becoming very powerful, so that for an application for funding, most researchers now have to have a community advocate on their research proposal, and that is to be invested in the design of the proposal, design of how whatever the project may be. And the advocate works alongside the researchers and is involved along the process of the research grant. And also there are community advocates being included in the assessment of grants when they go up to the actual funding stage, so that the community has a voice in the relevance and how the design of the project as well. So there's a recognition of the community voice in there, and making sure that research is translatable, applicable, relevant, and the language is such that the person who ultimately is at the core of this whole debate, that the person who has had a diagnosis, who is the fundamental center of everything that we do around sarcoma, because if it wasn't for that person with sarcoma, we wouldn't be doing any of this. We wouldn't need to. So they are the central point of all of this and need to have that voice of empowerment and a voice in the say of how things happen. And it's something that we as an organization take very seriously. And we do a lot of empowerment of the individual in the journey to allow them to have control in some of those things that they can have control on. There are a lot of things they can't have control on, but where they can, we try and support that. And having a say in what research happens and having a say in how that develops is an incredibly empowering thing for someone who has been through the journey. So that's just something that is happening over here.
You know, Mandy, you raise an important topic, the groundswell around the engagement of patients and the importance of including that voice. And we see a lot more in the United States developing around helping patient advocates become research advocates. So how do I help advocate for research? What do I need to understand about the scientific method and research to be a valuable voice at the table? And so I think there's incredible opportunity for us to partner with experts to help us in the advocacy community learn about research so we can lend our voices in a really appropriate way. So thanks for that comment, Mandy. Marcus, I see you have your hand up.
Yeah, thank you. I think this is such an important topic for the community, for the patients, but also for the doctors, and we will not be able to cover the whole topic within a few minutes. So I would like to be a little bit provocative. I'm very much interested not to talk about research, how we have done research during the last 20 years. I think we need to look forward how we want to do research in the future in sarcomas, but also in rare cancers. And for my feeling is we need something like a global think tank between patients and experts, how we want to do research. I want to follow statements Jonathan already have made. So for example, what about digital trials or virtual trials, or how you call it, remote trials? I think that's one of the part of the solution. But also, what about research priorities? We always talk about sarcomas. I think we need to go into the different subtypes and think about what are the research priorities from a patient perspective, but also from an expert perspective in different subtypes. We just talked about education. We need to find more patient advocates, and we need to educate them to become more involved and more knowledgeable in research so that they really can contribute in the research process. But also the question is, what is our philosophy on research within the next years? Are we willing to still to do phase 2, phase 3 trials, or do we need a more revolutionary way forward in, as we already have heard, about collecting data, do molecular diagnostics as early as possible, and then to guide patients into trials. So I think we need to restart the whole situation and really look into the future. What can we do better together with our medical experts in doing a better job in research for the next maybe 10, 20 years? How can we make research, for example, faster? Because sometimes it takes us 2 or 2.5 years to get such a clinical trial done, or to start a clinical trial. So I think we have a lot of challenges, but also opportunities to start such a discussion to go together on an international level. Thank you.
Yeah, no, you're absolutely right. This is just the beginning, and there's so much to discuss. Bill Tapas, for those not following along in the chat, had noted that larger cancer organizations have great interests, like ASCO, for example, working with ways to decentralize clinical trials. You know, what a fabulous opportunity that might pose for us. I think as we kind of wrap down, obviously we could speak for many more hours on this topic. Roger, I'll give you the last word on this section before we move back to Bernd.
You can still have a few more minutes, no problem.
Okay, good. Thank you. I was just trying to be you were very much a timekeeper for us. I wanted to keep us on track. Please, Roger, go ahead.
Thank you, Denise. I just want to enter a plea within the context of research for a wider focus on what we look at and what we measure. I want to see patient-reported outcomes in every clinical trial. You know, they don't have to be sort of rather bland quality of life instruments. They can be very specific instruments, for example, looking at pain, or looking at social function, or looking at return to work, these sort of issues. And I think we as patients should be asking our professional colleagues to be aware of this pressure, so that when the story of the clinical trial is told and the results are there with whatever the primary endpoints are met, hopefully, and the secondary endpoints met, hopefully, we have some patient-reported outcome endpoints to tell the patient side of the story alongside the medical side of the story. I think the two go hand in hand. And if we think of that in all our research, it will happen much more easily in those areas of research which go to the regulators, as in new drug trials, for example, where increasingly the FDA, the EMA in Europe, the MHRA here in the UK are now beginning to look at PROs as offering them valuable information which supports or maybe argues against authorization of a drug.
No, Roger, I know we've had this conversation that we've been working with the FDA representative who oversees the sarcoma portfolio, and she's been speaking to that it would really be terrific at some point in time to have, you know, primary objectives related to patient-reported outcomes. That would be, you know, and to hear regulators speak to that, I think that is important. Then we may begin to see some of our industrial partners and sponsors be more amenable to utilizing that those tools. And I know there are many opportunities within the patient advocacy groups to bring together, especially subtype specific patient groups, to help inform what is that right kind of tool to be utilized, what are the, you know, patient reported outcomes that are significant. And that's really where I think a patient voice bringing forward can be incredibly valuable and work collaboratively with the researchers.
Well, here in the UK, we've been developing sarcoma-specific measures which can be used, and that's been developed at University College Hospital in London. And as SPAEN, we've been working with EORTC and with the Netherlands Cancer Institute on a not dissimilar project, which will produce a library of patient-reported outcomes, which can be, if you like, picked off the shelf by sarcoma researchers. So they're sarcoma specific. Over 400 patients have contributed to the UK measures, and it's an even larger number for the one that's being done at NKI. So we are making steps as patients to help this happen.
Right. And it's critical. It's a critical voice. Mandy, did you have another comment to make? Oh, okay. You just had your hand still up. No, this is, Bill and John in the chat are echoing the importance of the critical component of the patient voice in developing PROs and validating them so that we have validated tools to utilize in the research. So I think that, you know, there's so much opportunity to collaboratively drive the research forward. And I think that right here we've identified two really keen areas. I think that from the standpoint of the void of research, I know that there can be many obstacles financially and just making regulatory wise, there are different competent authority regulations in different areas to activate trials. But I think this exploring this space of decentralized clinical trials may be really an incredible opportunity for us collectively as a group. And it's heartening to hear the overwhelming support from all areas to say that patient voice in the patient-reported outcomes and the inclusion of patient-reported outcomes in research, especially as we start doing these subtype-specific smaller trials that are going to be, you know, much smaller numbers, that this is going to be really important for evaluating the effectiveness of a therapy before we bring that forward. So with that, I thank you for your comments, and I look forward to us continuing this discussion of how we can really drive research forward together.
Thank you. Great. Yeah, thanks. And I think for a kickoff meeting, this was already a very rich and in-depth discussion. So thank you very much for that. And we would just let me just see. What we would just want to do now is maybe do a bit of a summary and also explore maybe other points that we have not yet captured or not yet mentioned. If I look to my list already, which I try to put things together, it's already a very long list. I have, I mean, starting with the early and accurate diagnosis, we talked about minimum global standards. We talked about overcoming barriers. We talked about exploring artificial intelligence and new technologies. I think all these remote solutions, especially for clinical trials, is highly interesting, of course. Awareness is a big topic, but we need really, as Marcus very nicely outlined here, we need really to clarify how do we want to achieve this and in which way we want to do that. But again, we can explore virtual solutions here. MDT, simple MDT is important here in this initiative. Global Atlas is a very interesting topic on our list, and facilitate cross-border healthcare. These are just a few topics I put down. I mean, Catherine, do you have anything to add here, or
No, I actually would echo what you just said. We traveled a long way within the last almost 2 hours now. So the only thing that we were thinking, I mean, when we prepared the meeting, we had a lot of topics that we actually had to cut down to fit into a 2-hour meeting. And we thought that maybe those are the most pressing ones, but we're a small group of people who prepared that. So I want to put the question out: is there anything that comes to your mind in terms of topics or even projects that we missed? Is there anything that we should consider, that we should add to our lists? Maybe feel free to just speak up. Paolo, I see you raising your hand.
I am biased. I think that networking is a very important topic, and I think that the medical community paid just I mean not such a great attention, I would say, to how to do networking. You know? But this applies to several things which have to do with how to organize our work. I mean, for example, even in a multidisciplinary tumor board, I remember that when we went through the applications of all sarcoma reference centers in Europe for Europe, we realized that the way multidisciplinarity is implemented across the European sarcoma centers may be completely different from one center to another. For example, which cases are discussed on a regular basis, how they are discussed, how they are reported, and so on. So I mean, the methodology, I would say, of the multidisciplinary networking and the networking in general is something which the medical community has never paid attention. And I think that the patient community may help, having us to reflect on how to do the different, very different kinds of networking which we do, and which, again, I repeat it, may be very different from one environment to another. But in any case, I think we should reflect on how to network.
This is a very, very important topic you're raising here, and I think we briefly touched on this before. So maybe there shouldn't be some kind of guidance how to network, but more show examples and best practice on how others do it and how you can implement it for yourself. I'm just gonna, in the interest of time, I'm just gonna hand over to Jean-Yves. You're raising your hand.
Yes, very quickly. I think one of the things that we could do all together quite easily is something which could be called the library of what is existing. I'm very impressed by the work which has been done by a patient advocacy group, research group, doctors group, nurses group, in many languages. And I don't think that we have an overall view of what is existing, and making the effort of gathering everything in a single repository where it could be accessible to everyone could already be an important step. And that would be only building on what is existing. I was impressed by what was existing when we started EuroCan, but I think much more is now existing. Library of things, in a sense.
Mm-hmm.
Good point.
Roger.
Yeah, as sort of a closing point from me, I'd just like to point out that the spread of age of our patient group is very different from that of other cancers. I'll leave the pediatric side end to one side for the moment, but I just want to focus on the younger adults from maybe 20 years of age through to 40 or 50, which is an age range which most cancers don't have to cater for. And that age group have rehabilitation needs, and there are opportunities for us to support that rehabilitation, I think, in more practical and powerful ways, coming from the sarcoma community, than relying on the community care, which is largely the way that rehabilitation happens at the moment. And somewhere in the discussion that we have over the coming months and years, I'd like to see us keep that age group in our minds and their needs in our minds.
Excellent point, Roger. Vandana.
Listening to all the discussions, I feel that it's always that we talk about what we would like to do, but have we ever asked the patients what they want to get done? So maybe, we can talk to the recovered cancer patients, recovered survivors, and ask them what their needs are, and talk about it to the patients on treatment, and then come up with some guidelines or research or anything that we need is in consultation with the doctor, with the patients, what they really want, or the caregivers. And we always forget the caregivers who play an important part in the treatment aspects. So I think that is important, and not what we think should be done or what we think is important for patients.
I just see Corey adding the bereaved loved ones. So another group that we don't have in our focuses just now. Anything else you would like to add? Any kind of project that comes to your mind at the moment? I mean, it's a brainstorming, so just go wild. Okay, maybe we're just all a little tired, but anything else? Oh, I see Mandy and Vandana. Vandana, you're still raising your hand? Okay.
I think Mandy and John are new on the block.
Yeah, yeah. Okay, Mandy, go ahead.
Yeah, I just wanted to, I forgot what I was going to say now. It's getting late in my night, and the age is catching in now. I'm getting old, and
no, it's
way
late,
past
yes.
my bedtime. I'm sorry, it's completely gone now. Apologies.
No worries. John, would you like to add something?
Oh, yeah, sure. Yeah, so I would just like to say, and I think I can speak on behalf of the other sarcoma physicians, nurses on this call, is that we're here to help. Don't hesitate to reach out to us if you're having a meeting or there's anything that we can do to help you raise awareness. We're all here because we want to. So don't hesitate to reach out to any of us for anything that you need, whether it's in person or these days doing things on Zoom. It's, you know, it's simple for us to participate, and we'll help however we can.
Thank you, John. We know that we've done it already, and we really, really appreciate your commitment, your dedication to help us move forward and well, improve the situation for sarcoma patients. I feel that this is kind of a good closing word to hand over to Bernd. Is it?
Yeah, thanks, Catherine. I think we have talked about everything, and I guess we need more than 20 years to do all this we have mentioned today, at least. Even if we are already or almost coming to an end, I would not miss to welcome one of our participants who I think joined a bit later, Rick Haas, because he's our CTOS president this year, and he also helped us very much to make this meeting today possible, and therefore I would like to thank him for that. And Rick, welcome. Maybe you also want to say a few words at the end, but then I will close the meeting.
Oh, thank you very much for your kind words, but actually you did all the work. So, what you say, I echo to you back again.
Okay, thanks, Rick. As it is usual for such a meeting, for such a virtual meeting, of course, we have to do a group photo, and that's the thing we want to do next. So please all turn on your cameras if you want, and then we can have a photo together.
And smile.
And smile, yes.
I want to thank you for announcing it, because I've had like 5 different conferences in a row take candid shots of me talking, and it's not ever pretty. So having the ability to smile on cue is much, much appreciated.
Okay, Michi, do you have that?
Yes, it's done. Thank you.
Perfect. Okay. So having said that, I really would like to thank you for your participation. And as I said at the beginning, as an output of this meeting, we really would like to put together what we have discussed today. We will develop a joint paper, a joint manuscript we also try to publish. And as said before, this is only the start, and this will certainly be an ongoing project, and we aim to work on this priority list we will try to define in this paper, and this is definitely something for the next couple of years, and we for sure we will rely on your participation. So thank you very much. Thank you all for your attention and for your fruitful discussions, for your collaboration and dedication to make this project a real success for our patient. Thanks a lot, and seeing you soon, and wishing you all a very great CTOS. Thank you very much.
Thank you, Bernd.
Thanks.
Bye-bye.
Thank you very much.
Bye, thank you.
Thanks, Catherine.
Thank you very much.
Bye.
Congratulations. Very well done.